and welcome to the Complex Care Journal Club podcast. My name is Kristina Malik. I am a complex care pediatrician in special care clinic at Children's Hospital Colorado and your host for this episode. In this podcast series, we seek to discuss emerging evidence in the care of children with medical complexity and its implications for practice. I am delighted to have Dr. Shaikh from the University of California, Davis Health joining me today. She is the lead author in implementing strategies to prevent home medication administration errors in children with medical complexity in clinical pediatrics. This publication was in collaboration with the American Academy of Pediatrics Council on Quality Improvement and Patient Safety.
Thank you so much for having me, Dr. Malik.
The publication describes the implementation of a toolkit that was developed out of policy. So, first, Dr. Shaikh, I'd like you to share a bit about your toolkit development and starting with any gaps you identified.
Yeah, of course. So, one of the issues that we had found emerging again and again in our work as patient safety advocates was the issue around pediatric out of hospital medication errors. And we work with kids in the hospital, and once we send them home, especially if they're sent home with multiple medications, we saw that errors were just really frequently occurring. This was nationwide, reported in the literature, and it's essentially a very serious public health issue, especially in children with medical complexity. And we'll discuss that more in terms of why this population faces more challenges. But when you look at the general population of pediatrics, there are about 200,000 out of hospital medication errors in children that are reported annually. And this is to poison control centers. So these are reported errors. And so I believe they are just the tip of the iceberg because there must be more errors that are unreported, right? And if you look at all of these numbers, a third of them actually involve young kids who are less than 6 years of age. And it's one child every 8 minutes that suffers from out of hospital medication errors. So it is a serious public health issue. We look at why these are occurring. They take the wrong medication, the wrong dose, it's wrong concentration, wrong duration of time. There's some interaction issues we see, allergy issues. So, yeah, it's just a pretty serious problem that people should be paying attention to.
So, can you tell me a bit more about the methods that your team used in developing the toolkit?
Yeah, so our team felt very strongly that once you have a best practice guideline or a policy statement that's out there, it really needs to also pay attention to implementation. So I'm a general pediatrician and I work in the primary care setting. And there's so many challenges, as you know, in primary care settings with all of the many best practices and guidelines out there, trying to get them to the front lines. There is such a huge gap, right? And so how we went about trying to create the implementation toolkit that's a companion to this policy statement was, and just to give your listeners a background as to the magnitude of the kind of collaboration that's possible in a community of pediatricians. The AAP, as you know, is a large membership organization of almost 70,000 pediatricians. And the AAP has over 60 communities within it. They're called councils and sections. And the AP members join them to connect with each other, with like minded professionals, either by a shared pediatrics subspecialty or an area of interest or a stage of life. So the group I worked with is COQUIPS, or the Council on Quality Improvement and Patient Safety. And it's a community that represents over 700 pediatricians who are specifically dedicated to quality improvement and patient safety in our healthcare settings. So we work on creating policy, developing educational programming, developing and promoting advocacy initiatives, supporting the translation of policy and education into practice, which is what this toolkit demonstrates. It's just one of the resources that came out of CoQuips. So it started with one of our colleagues at CoQuips, Shauna Yin. So she and her colleagues got together and developed what was then a new policy statement preventing home medication administration errors that was published in Pediatrics in 2021. So, a group that with somewhat of an overlap with her group simultaneously developed the toolkit to be released concurrently. and the resources facilitate actually the implementation of this policy statement. And we had about 15 Toolkit developed members who had a range of expertise. So they were all COQUIPS members, and they had expertise in the area of patient safety and medical errors. We also had two family advisors that helped us. So we started off by conducting a cause and effect analysis using sort of the fishbone diagram, root cause analysis kind of framework, but trying to do a deep dive into what people issues, tools and technology issues, tasks issues, and environmental issues within the context of an organization could result in these home medication errors that these children faced when they left the hospital. And we found that there was quite a bit of gap in outpatient practices for identifying, reporting, and reviewing errors. And so, to give you an example, one of the things that emerged was the need to develop a practice based error reporting system. These error reporting systems or incident reports are really pretty common in the inpatient setting, but there is a gap for sure in the outpatient setting. And we really thought that we need to develop interventions at our organizational level, not just at the individual provider level, in order to bring about sustainable change. Yeah, so that's sort of the process we went through. It's large group brainstorming, trying to develop a draft of toolkit, getting feedback from co-quips members, revising sort of an iterative improvement process, getting feedback from parent advisors, and basically trying to mine the expertise that is the American Academy of Pediatrics and the Council on Quality Improvement and Patient Safety.
I'm really interested the role the family advisors played on this team. Can you tell me the family advisors' impact on the toolkit?
Yeah, the family advisors played an excellent role in making sure that we stayed true to the real life issues that our were facing. When you're a clinician, we frequently have our own assumptions about what's going on in a patient's life. And I think having family advisors there to keep it real for us really made a difference. For example, one of the things that they brought to attention was the fact that children frequently use their medications on their own as early as age 11. And only about half of preteens and teens actually know these side effects or issues, or maybe less than half, that these medications have if taken wrongly, right? So education should be directed not just to parents, but also to preteens and teens. Some of the other issues they brought up is that dosing devices that come with medications, there are families or patients who may not end up using these dosing devices, and they end up using household teaspoons or tablespoons. And that was brought to the forefront, and we paid a lot of attention to that. And then the storage of medications, making sure that these medications are stored safely. So again, just making sure we knew about the realities of these issues. Some of the other things that they made us really aware of and pay attention to were things around the issue of health literacy, and the fact that there is a lot of variation around how caregivers and patients process information and absorb and retain information. So, just again, being mindful of that. So, I really felt that they were an invaluable part of our team in making sure we got to a product that just, wasn't just a good product, but it was a product that was really realistic and mindful of the context in which it will be implemented.
Yeah, in your toolkit, there is a section of resources specifically for patients and families. And I appreciated that because I feel like some of the real life examples, like using spoons, was something that providers should think about talking about with families. And it's often something we don't think about. So I really appreciated that in the toolkit. What opportunities and challenges did you identify while developing and implementing the toolkit? Specifically, what advice would you have for others interested in developing toolkits in general and important aspects of implementing care for children with medical complexity?
Yeah, so one of the challenges is the wide variation of practices and clinicians that the policy statement or the toolkit is going to be touching. There is a range of practices in terms of geography, in terms of practice size, in terms of practice focus that will be interested in improving patient safety for the children and the families they serve. And so, developing a toolkit that is not really prescriptive but can be customizable or adaptable to the needs of practices is always a challenge and something that we had to grapple with, right? One of the ways around it is to, in these sorts of toolkits, to develop a menu of options where practices then have the freedom to pick one or two interventions that they can implement that are realistic for them. So, just making sure that there is the ability for sub customization within your recommendations, I think, is the first key thing that we learned and worked with. The second thing is to look at your population carefully and try to narrow down your population as much as possible so that practices have a clear idea of what your toolkit is hoping to accomplish for what kinds of children. So, for example, our toolkit focused on children with medical complexity. And we started off with the toolkit intending to address all challenges in pediatric primary care, but then quickly realized that we needed to narrow our recommendations down to specific populations, just to make sure that we were really efficient with the limited time that especially primary care clinicians have with their populations. So yeah, so there's several challenges that we faced, but I think we did overcome them by trying to carefully select out a population of interest and then also making sure that whatever recommendations we have the option to be customized to the specific needs of the context.
Yeah, and one of the reasons why we picked this article and you to invite it was that this is one of the few frameworks out there that, while it comes from a policy made for all children, it really has a focus on the kids who are most at risk, children with medical complexity. And I really appreciate it. Like you mentioned, for general pediatric providers, they might only have a few kids with medical complexity, and actually, they might only have a handful of kids on chronic medications. And you mentioned that obviously you had to offer many options based on the practice and who they serve. So, what do you think the implications are for clinical practice? What do you recommend for members of interprofessional care teams who care for children with medical complexity based on your intervention and the findings from implementing it?
So, many clinics around the country, clinical settings essentially, have reported that one of the areas they need to focus on to improve patient safety in the outpatient setting with medications is improving communication with patients and families. One big issue related to that is health literacy. So, nearly a third of patients in the United States, and the number that's out there is 20 to 25 million parents in the United States, have low health literacy. And that's different from literacy. Basically, health literacy is understanding health instructions, implementing them accurately, right? So, this low health literacy places our families at increased risk for medication administration errors. Again, when you look at the statistics out there, only 15% of parents are considered to be proficient in terms of health literacy. So, again, the take home there is that the majority of caregivers we work with, parents and caregivers, struggle with this issue. Then, on top of that, you have issues around non English language preference, right? And again, there are about 15% of US adults have challenges around language issues. So, health literacy and language issues play a large role in risk for medication errors. And so, strategies to improve communication with our patients and our families are extremely important to make sure that medications are used safely. So, some of the things that are actionable are providing really straightforward instructions that are concrete and patients can follow more easily. And this is a big issue because about 40 to 80% of medical information that patients are told during office visits is actually forgotten immediately. And nearly half of the information that people retain is actually retained incorrectly. So when you actually get down to what's implemented at home in terms of medication, the statistics can be pretty scary. So one of the things that is really powerful and actually is really magical when I've tried it in my own clinical practice, and I just use it really frequently, is this technique called teachback, Teachback essentially is a way to make sure that you, the healthcare provider, explained information correctly. And it's not really a test or a quiz of the patients. Actually, it's more reflective of how good or bad a job you did as a clinician explaining information. So I find that really good in terms of me getting feedback on my communication skills is teachback. So basically, once you finish transmitting information, communicating information to the patient or the family member, then you ask them to explain in their own words what they need to know or do once they get home. You communicate this obviously in a way that is non intimidating and doesn't feel to them that you're testing them. You basically ask them to repeat back to you what you said and what they'll do once they get home. And it's a way for you to check for understanding. And if needed, use that as an opportunity to re explain and check again. It's a research based health literacy intervention that promotes adherence to medications, it improves quality, improves patient safety. And the concrete steps are essentially the first one is you, as a clinician, explain to the patient a new concept. So, the dose of their medication, the dosing device they use, for example, or their diagnosis or their treatment plan, and you explain it to them in small chunks called chunking. The second step is then the patient or the parent explains or teaches back what was told to them. And then if the patient can't actually show that they've understood, then you try to explain in a different way and then again ask them to teach back. It's really illuminating to me. I think it's really helped me improve my practice and my communication skills as well when I've used teach back. Just yesterday in clinic, I used it with a teenager to explain to them about their asthma medications. And they did such an awesome job in explaining things, and I was able to perform minor corrections in their understanding of the frequency of their medications, which I think was really effective and they learned from. So, if there's maybe one takeaway from this podcast is for people that haven't used Teachback, just like go back and try it on one patient and just use that as a way for you to get feedback on how well you're doing with communication.
I love that idea. I mean, I think you also just even point out the fact that talking about medications, and in the toolkit they talk about that there just needs to be conversations about adherence and getting rid of meds when they're done. I mean, I really feel like for kids with medical complexity, this is probably one of the biggest things we should be doing. We know that by stopping meds or getting rid of duplicate medications, you're reducing the risk of errors. I really appreciate the toolkit pointed that out. What message do you think your toolkit has for patients and their families from your project? I know you mentioned there's a whole section on resources that are for the patients. Can you tell me a little bit more about what a takeaway for families could be?
Yeah, so part of the toolkit was trying to direct families to actionable and clear education material that they can get their hands on really quickly online. And there is a variation of patient education material online, and we wanted to make sure that patients had access to the most accurate information out there with medications. So the toolkit does have references for patients and families to learn about things like liquid formulations of medications, for example. So, one of the issues with liquid formulations are that they actually account for over 80% of pediatric home medication errors, especially in young children and in children with feeding tubes. Trying to make sure that patients and parents essentially learn how to use liquid medications. With over the counter medications, we've sometimes seen that caregivers face some struggles navigating these dosing charts that are behind these bottles to determine the correct amount of medications to give their child. Weight based dosing, especially, is a challenge. How to dispense over the counter medications, dosing, measurement, disposal of medications once you're done with the course. The toolkit has resources for and links to videos, handouts, tables, pictographs. So, pictographic dosing diagrams are really effective. They've been shown to have more than five-fold reduction in dosing errors, prescribed daily dose medications when you compare them with text based information only. Using these videos, handouts, tables, and pictographs that are really graphically easy for parents and caregivers to follow. So, some of the messages for patients are try to pay attention to information that comes with liquid formulations. The second one is dosing cups, right? So, we definitely prefer with children oral syringes instead of dosing cups to measure out liquid medications. Dosing cups have been associated with greater than threefold increases in errors occurring compared to oral syringes. So, again, it's not just the medication, but also the device that comes with the medication we need to pay attention to. And it's really important to counsel about not using household spoons because caregivers have about a fourfold increased odds of just grabbing a spoon when dosing was given in teaspoon units. So, trying to give instructions in milliliters versus teaspoons is really important. So, those are some of the messages for caregivers.
So, one component of the toolkit that I mentioned earlier I really liked was conversations about adherence and disposal of meds. And I really felt like in my clinical practice, I've been really trying to expand this, not only having discussion around medications, but also if a kid really needs a medication still. I think, especially for children with medical complexity, they're often started on medications in very medically critical times. And then we never really think about trialing them off. An easy example is like reflux medication. I didn't know if your group talked at all about including a component about trialing off medications, or if you feel like that's something that's outside of the scope of the toolkit.
Yeah, you bring up a really good point. It's really important to encourage discussion around if medications are still needed for a patient's medical condition or their symptoms. One of the ways we can help with that is to integrate home medication information accurately in the electronic health record and make sure to conduct a medication reconciliation process at every visit is really key. Yes, we addressed that point, and great detail in the toolkit is the ways to do medication reconciliation and strategies to avoid the issue of indefinitely continuing medications that are not needed in patients. So, one of the issues in electronic health records is just the amount of redundant paperwork in after visit summaries that patients get when you actually print out after visit summaries, and then replacing that redundant paperwork with information that's more helpful is key. And paying attention to social determinants of health is really important as well when you're talking about people accessing care frequently in the medical home so that we then are able to supervise their medications more carefully. So you're right, making sure that at every visit we ask about all medications as clearly as possible, record medication doses that patients need to be on, try to get parents and older children to sign on to patient portals in their electronic health records so that there is a clear shared understanding of the medication dose and whether it needs to be taken at all. I think that we can use EHR portals really well that way. Again, really just a plug for the medical home model and care coordination in the medical home. Primary care pediatricians and primary care providers really are a line of defense against medication issues that our patients face, and keeping our patients safe outside of the hospital walls is our responsibility. And so, just again, the medical home model is really a great way to make sure that we're all watching out for our patients and they have a place where we check and cross check the medications they're on.
Yeah, one way we do it in our clinic is we actually print out the medication lists. It's a great reminder because it's often something you otherwise don't think about.
Yeah, and that's a visual cue, isn't it? That's a QI, quality improvement intervention. You're getting a visual cue, and that actually prompts you to essentially conduct medication reconciliation at the point of care right there in your clinic.
So, what is the next steps with your toolkit? Are you going to support quality improvement initiative through AAP? I am hoping so. I would love to join.
That's a great question. I think that our goal was always to move to the next step of action where we design and implement a quality improvement collaborative where we engage a diverse range of practices in addressing this issue around medication safety in home settings. And so that is definitely one of the next steps we need to take. One of the issues that we saw that clinicians around the country, I think there is definitely a gap that could be addressed through a quality improvement collaborative is this issue around lack of practice based error reporting systems, and the fact that in the inpatient setting there is culture around reporting incidents and errors and near misses, but there's several practices around the country that may not have that as part of their outpatient culture. And so learning not just from errors but from near misses where essentially there is no harm but really could have been harmed if the error had then kept going on is really important. So, yeah, I would be thrilled if this work was translated to a quality improvement collaborative, and would be happy to partner with any of your listeners who are interested in collaborating the Council on Quality Improvement and Patient Safety on this initiative.
Thank you so much for your time, Dr. Sheikh, today, and thank you to your team for advancing the field of complex care.
Thank you for having me, Dr. Malik.
Thank you to our listeners for listening today to the Complex Care Journal Club podcast. We aim to highlight research that has the potential to be practice changing, that values patient and family engagement, and is relevant across disciplines and diagnoses, and uses high quality or novel research methods. We invite you to join the conversation by suggesting an article that you would like to see discussed in this podcast using the form provided on the Open Pediatrics YouTube channel. Thank you for joining us.